Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Mahmoud Badran. I am an associate professor of orthopedic surgery and traumatology, Assiut University Hospital. And I'm going to present you this presentation about the minimally invasive fixation of acetabular fractures. So let me ask you a question. If you have a male patient, he is 27 years old, he sustained a knee trauma and came to you with history of clicking and locking of his knee. After doing MRI for such patient, we found injury of the posterior horn of the medial meniscus. So what are the options for treatment of such patient? How many of you would like to conserve with such patient, and how many of you would like to go for arthroscopy? I think that most of you is going to go with arthroscopy for such patient because he has a history of clicking and looking. But what happened if I told you that I'm going to do an open arthrotomy for such patient? I think that most of you are going to have objections about this because the arthroscopy now is the gold standard in treatment of any injuries related to sports injury related to the knee. However, I'm going to tell you that this was not the situation in 1962 when they performed the first knee arthroscopy. There was a lot of objections against doing such a minimally invasive technique in treating sports injuries related to the knee. Why I'm giving you this introduction? This is the first objective of my presentation today, is that not to call any prejudgments about the minimally invasive fixation in stabilizing acetabular fractures. And in order to know that, we have to know when to use the minimally invasive fixation. We have to realize that there are a lot of difficulties against applying minimally invasive fixation in acetabular fractures, and we are going to solve them. So the rationale why we are doing minimally invasive fixation. First, we are doing it to avoid complications of extensive surgical approaches like infection, like blood loss, like heterotopic ossification, and so on. And also, we can avoid complications of recumbency, especially that happened with conservative management. And also to allow early weight bearing of the patient and rapid return to function. So the principle of doing minimally invasive fixation of acetabular fracture remain the same as treating it with open extensive surgical approaches. Put in your mind that acetabular fracture is an articular fracture, and the principle of treating is by achieving anatomical reduction, absolute stability, and leg screw fixation and rigid fixation. So if we achieve anatomical reduction of such fracture, if we apply leg screws that pass through the columns of the acetabulum, this is the main, or this is the rationale, or this is why you are doing, or how we are doing minimally invasive fixation in treating acetabular fractures. But we have certain prerequisites. First, you have to know that the pelvis has a 3D anatomy. So you have to be familiar with this in understanding the anatomy of the pelvis, the presence of the intrapelvic organs, the columns, the imaging of the pelvis and acetabulum. You have also to be very familiar with the classic open surgical approaches, and you have to put in your mind that it has a learning curve in treating such fractures. However, we have a lot of limitations. First, we have the indications, the timing, the reduction of the fracture, and safety. So let's begin with the indications. Actually, minimally invasive fracture can be applied successfully in treating non-displaced fractures, but it has to be affecting the weight-bearing area. As you see here, this fracture is present in the roof or the weight-bearing area of the acetabulum. This is measuring the roof arc angle, which is 40 degrees. So it can be treated by percutaneous anterior column screw, as you see here. Here we have avoided complications of recumbency for those who are going to prefer to do conservative management of such fracture. And also we have allowed early weight bearing for such patient and rapid return to function. So we have the advantage of minimal invasive fracture fixation, and also the advantage of allowing rapid return to function through achieving rigid fixation of this acetabular fracture. So non-displaced structures can be applied also in cases of unstable conditions. Like what? Like if we have a sacroiliac joint dislocation with a transverse fracture acetabulum here. Okay, this fracture actually is not affecting the weight bearing area or maybe touching the weight bearing area. However, this is considered as unstable situation. We have here what's called as an unstable floating iliac bone. The iliac bone is not continuous again with the pelvis, neither continuous with the sacrum. So in this situation, we can apply reduction of the of the sacroiliac joint and fixation by iliosacral screws, and also we can apply anterior column screw as you see here, fixing the iliac bone in relation to the pubic bone. So we have, this is the second indication. Also we have in this example about the transsacroiliac acetabular fracture. Here the sacroiliac joint is dislocated, transverse fracture acetabulum fixed by two iliosacral screws and fixation of the acetabulum by anterior column screw and posterior column screw. Again, we can apply minimally invasive fixation in displaced fractures, but with the maximum of 20 millimeter, and on condition that this fracture is simple fracture. Okay, avoid the complex fractures, avoid the fractures with extensive amount of displacement. Okay, in such fracture, if you are successful in achieving adequate reduction, we can apply also the minimally invasive fixation by applying the leg screws through the columns of the acetabulum. So now we have after knowing the indications of minimally invasive fixation, we can go with the timing. You have to do minimally invasive fixation in treating acetabular fracture within the first week after injury. Otherwise, the fracture hematoma is going to be organized, and this will prevent the reduction of the fracture. So going now to the third limitation in treating in fixing acetabular fracture using the minimally invasive fixation, which is the most important thing, which is the reduction of the fractures. Put in your mind that the reduction has to be anatomical reduction, okay? And you can achieve anatomical reduction through either two ways, either indirect reduction or direct reduction. So going with the indirect reduction, this depends on closed reduction only. You can just manipulate the hip. You can apply longitudinal traction by traction alongside the limb, or you can apply a corkscrew through the proximal femur, and you can apply here a side traction to disimpact the fracture area here, or you can apply the joystick technique by applying a shank pin through the iliac bone, which you can use it to manipulate the whole acetabulum until fixing it by percutaneous screws. Or if you failed to achieve closed reduction, you can use limited minimally invasive approaches like the mini pararectus approach, where you can use some instruments to manipulate and directly manipulate the fractured fragments of the acetabulum. This approach was described by our team, myself and Professor Osama Farouk and other colleague professors from Assiut in Injury Journal in 2014, for those who wants to know some information about the mini pararectus approach. So we have two kinds of reduction here. The anatomical reduction, this is the only way. Either we are doing it closed or open reduction. So we have two kinds here of displacement. Either we have what's called as a gap displacement, where the fractured fragments are in the same longitudinal axis as you see here. So if we apply just only the leg screw, it can compress the fractured fragments, and as you see here, the fractured fragment is reduced anatomically. But also we have another kind of displacement, which is called the translational displacement, where you have the fractured fragments not in the same longitudinal axis to each other. So the idea here is to use a mini incision and to put instrument to push this fragment until they are in the same longitudinal axis, and then you can apply your leg screw and compressing the fractured fragment. So now going to the fourth limitation in applying the minimally invasive fixation, which is the safety. And what's meant by safety? Safety of the corridors that the screws of the acetabulum passing in. You have to assure safe corridors for these screws, because if the screws is going to penetrate the pelvis outside, it's going to be loose. If it penetrates the pelvis inside, it will lead to injury of the some important intrapelvic structures, or it may penetrate the hip itself. So how to achieve safe corridors in treating acetabular fractures? First, you have to be familiar with the 3D anatomy again, and you have to be familiar with all images taken with the pelvis and acetabular. As you see here, you have to know what is the value of the iliac oblique view, what's the value of the obturator oblique view, what does the iliac oblique view helps you with. Here in the screw, it will not penetrate through the hip, and also it will not go to the greater static notch. And with anterior column screw, you have to know the importance of the outlet obturator view, and also with the inlet view, you have to know all imaging related to the pelvis in order to assure safe pathway for your screws. And also you have to know the kinds of periacetabular screws which we can use. We have four kinds here. We have the anterior column screw, the posterior column screw, or the supraacetabular and or LC2 screw, and also we have the magic screw. First, for the anterior column screw, it's simple. It's the screws that pass from the iliac bone to the pubic bone through the anterior column. It can be applied in two ways, either antegrade as you see here, or retrograde from the pubic to the iliac bone. The images needed here, we need the outlet obturator view to assure that the wire is not passing through the hip, neither going superior and entering inside the pelvis. And also we need the inlet iliac view to be sure that the wire is not going anterior, neither going inside the pelvis. And then you can apply it here. This is the antegrade anterior column screw, and here this is the retrograde anterior column screw. And also we have the posterior column screw. The posterior column screw has, in order to be done in a minimally invasive way, it has only single entry, which is the retrograde posterior column screw. The screw is going to pass from the ischium towards the iliac bone here. Be careful with this screw, otherwise you are going to penetrate through the greater static notch or going to penetrate through the pelvis. So you have only very, very narrow corridors. That's why the posterior column screw is rarely to be used, because it is it needs a very high learning curve in order to introduce this screw. As you see here, this is the retrograde posterior column screw. Okay, and also we have what's called as the supraacetabular screw, or LC2 screw, or lateral compression type 2 screw. The direction of the screw is directed from the anterior inferior spine, as you see here, directed to the posterior superior spine. If it is directed in this way, it's called LC2 screw, which is lateral compression type 2 screw. And if it is directed from anterior inferior spine to the greater sciatic notch, is called the supraacetabular leg screws. And in order to achieve these screws, you have to do the TP view. Okay, it's known for those who are doing pelvic fractures. And also you have to do the iliac oblique view. Going now to the magic screw. This one can be used to treat or to fix acetabular fractures, especially the transverse element if it affects the quadrilateral plate. With this wire, the screw here is going from outside of the iliac bone, fixing to the quadrilateral plate. Okay. Why it's called magic screw, I don't know why, but this is just a name, and I had some difficulties in doing this screw, and I don't think that it is a magic screw, but okay, they named it magic screw, then okay, we are going to name it also magic screw. So the magic screw needs here to be careful, because either you are going to penetrate inside the pelvis or penetrate also inside the hip. So you have to do the iliac oblique view and also the inlet view. Otherwise, you are going to go inside the hip. Here, this one here is the magic screw. Now we have to know when not to use the minimally invasive fixation. You have to avoid it in cases of posterior wall fractures. You have to avoid it in cases of associated impaction, in comminuted fractures, in entrapped fragments, in fractures with big amount of displacement, or if you failed to achieve anatomical reduction either using the closed method or the open method. So we have here a case. Here, as you see here, this patient with double level anterior column fracture. See the amount of displacement that's present here and here. We decided to go with this patient with closed reduction and also with mini pararectus approach, where we introduce this picador to manipulate the fracture fragment until we achieve the amount of reduction of the fracture, and then we fixed it by a wire here, And now we are going to go with this leg screw. Okay, so this screw here is going to be not perpendicular to the fracture site as you see here. So what's going to happen? The same principle. When your leg screw is not perpendicular to the fracture site, this is what's going to happen. So in order to avoid this, you have to do what? You have to do what's called as anti-glide plate. You have to put something to prevent this sliding from the fracture, and hence you can achieve now a rigid fixation using a leg screw. And that's why what happened exactly with such patients. After doing the mini pararectus approach and fixing it with the wire, we just put a plate here as an anti-glide plate, and then we applied our leg screw. This technique also was described by us. It has increased the indications of minimally invasive techniques to include more displaced fractures in fractures that's not simple. Here, as you see, the plate could be seen from this small window. This paper has been published already in the Current Orthopedic Practice in 2019 by our team also. Here you can see the mini pararectus approach, its position and its size. And through this approach, you can apply small plates which can hug the quadrilateral plate or the acetabulum, and it will add to some stability beside the addition of the peri-acetabular screws. So now, at the end, you have to know the take-home message. First, please don't call any prejudgments about anything new. You don't know what's going to happen with the progression of time and with the advancement in the ways of fixation of acetabulum fractures. And also, we have to remain with the same principle. Anatomical reduction is mandatory. Okay, timing has to be done within the first week. If you failed to achieve reduction either closed method or mini open reduction, this is an indication of doing open approaches and standard fixation. And you have to understand the 3D anatomy of the pelvic ring is essential to keep safety of your screws. Thank you very much.